Idaho Matters podcast is brought to you by St. Luke's On-Demand Virtual Care, which allows patients to see a provider from their home using a computer or smartphone with on-demand care for common ailments, such as a cough, sore throat, or a sinus issue. More information at stlukesonline.org. From Boundary to Bear Lake, Fremont to Payette, Oahe to Oneida, there are interesting people, places, and histories in all of Idaho's counties. And Idaho Matters wants to share it with you with stories from all 44 counties that make up the Gem State. Email your ideas to idahomatters@boisestate.edu or use the Talk to Us feature in our app, available on Apple and Android, and tune in each weekday at noon for Idaho Matters. From the studios of Boise State Public Radio News, I'm Gemma Gaudette. This is Idaho Matters. The Centers for Disease Control and Prevention has a new director. It comes after months of the department weathering staffing cuts and disease outbreaks without an official leader. Dr. David Pate, the former CEO of St. Luke's Health System and the co-author of the book, Preparing for the Next Global Outbreak, is joining us today to talk more about this. Hi, Dr. Pate.
Hi, Gemma.
And folks, remember, if you have a public health question, send us an email, idahomatters@boisestate.edu. Okay, so Dr. Pate, we know that Susan Monarez is a scientist. She's also a longtime civil servant. She was confirmed yesterday as the new CDC director. But what else can you tell us about her?
Well, she is a PhD. She has her PhD in microbiology and immunology. So the good news is she has to understand how vaccines work and their benefits. So that's a plus. She's long served in the government, and that is a plus because she is walking into a very complicated and dire situation with about a third of the CDC employees gone, increasing risks for a pandemic. And so she does have the basic understanding of how government works, how the CDC works. And she actually has a lot of experience with, she worked with the White House Office of Science and Technology Policy on antimicrobial resistance, which I think is a huge public health threat that gets very little talk about. She understands AI. She has led some initiatives with AI to try to help mental health and other problems. We know she knows science, and we know she, on paper, is certainly well qualified. The thing, of course, that's giving us heartburn is Secretary Kennedy doesn't, and President Trump is not going to appoint someone that they don't think is going to toe the line. So how she's going to balance this is a great concern to many of us.
So, Dr. Pate, you mentioned RFK Jr. She is really going to be walking a fine line. And what I mean by this is that in her very own words, during her confirmation hearing, she stated, and I'm quoting this, vaccines save lives. And she said she will continue to prioritize vaccine availability. She was specifically asked if she would make sure that vaccines stayed free and available for children in the United States. Now, this is truly in contrast to her boss's beliefs. So how does she walk this line and frankly stay in this position potentially?
Yeah, I don't know that she can. I think our first concern is, yes, she did say that during her Senate confirmation hearing, but RFK Jr. said almost the same thing and then got into office and shortly began, he said he wouldn't dismantle the advisory committee on immunization practices. It's dismantled. He said he wasn't going to try to take away vaccines. He's already, over objections of the scientific staff, he already removed the approval for the COVID vaccine in pregnant women, which we know
Mhm.
pregnant women, in fact, the CDC acknowledges and published a paper not long before this that pregnant women are at high risk. Um, so, uh, Dr. Maneras did say some reassuring things, as you point out. However, she also said something that I found particularly troubling because I think she knows better. And so that does worry me. And she said that the secretary had prioritized public health activities for reducing maternal morbidity and mortality. I don't know any
Mm.
other scientists and physicians that are reputable that would agree with that statement, especially in light of what I just mentioned about
Mhm.
RFK Jr.'s taking the approval for the COVID vaccine pregnant women.
So, also since January, the CDC has seen funding cuts. As you mentioned, they've seen staffing cuts. In fact, folks who work there have told NPR that the department is in chaos. So, the other question, Dr. Pate, is how in the world does she also work to figure all of this out and be transparent? Because this is also something that came up in our confirmation hearings, which frankly, it seems since the COVID, at least, and during COVID, the CDC struggled with being transparent.
Mightily so, which was a great deal of distress for many of us that they were not being transparent enough. I hope that perhaps the fact that the reason she's been appointed and now confirmed was because the initial candidate that President Trump appointed did not get confirmed and withdrew his nomination. And so, that was back at the beginning of the year. Now we're on to the second one, and there's been no really authorized or fully deputized CDC director this year so far. I'm hoping that would make RFK Jr. and President Trump very reluctant to terminate her, and perhaps that will give her some of the fortitude she's going to need to stick to her guns. She said that she is going to act based on quote unquote gold science evidence. That is what you ordinarily would like to hear. However, that phrase has been co opted by these disinformation purveyors and anti
Mhm.
vaxxers to mean whatever they say is gold science, and that's not how it works. So I am nervous. What I'm hoping is she is the kind of person who can speak truth to power. That doesn't seem to be a common trait in the administration right now. So we'll see. I don't question her integrity. I've got no reason to doubt it based on her own actions. It's just the circumstances are very concerning right now.
So, in other news, Health and Human Services Secretary RFK Jr. was actually in Boise last week. In fact, he was meeting with Governor Little, as you and I were on the air last week, Dr. Pate. During his visit, as you know, he declared Idaho as the most having the most medical freedom of any state in the nation. I'm curious about your thoughts on his visit, about him saying this, because I would think, to play the devil's advocate here, that there are many women in the state of Idaho who would disagree with that statement when it comes to the idea of medical freedom.
Many women, most all doctors, lots of hospitals. Yes. So surprisingly, I was able to be on the radio show last week and wasn't invited to that little get
I'm
together
shocked.
with the secretary. It's shocking, but the problem is that we are nationally getting gaslighted, and that is that, as I just mentioned in the previous discussion how they are using phraseology like gold standard evidence, and they have completely co-opted that and perverted it away from what it really means. When we now hear about medical freedom, which before all this nonsense, if you would have asked me, I would have said, yes, of course, I agree with that. In my practice, I've always presented my patients with the information, and they get to decide whether they want to take my advice or not, or whether they want to seek a second opinion, or whatever. That's fine. I am a proponent of medical freedom, but that's not what medical freedom means now. Medical freedom means that if you believe in the disinformation, if you don't want to do things, then you have the freedom to do that. However, ask your listeners, who by and large tend to be people who want to take care of themselves, want to protect their families. Ask them if they still have the same freedom that they had before. They don't. It's been taken away. We've already seen difficulties in getting the vaccines. We are very concerned that the latest effort by this newly replaced vaccine advisory committee is likely going to mean that vaccines that people want to get, now they're going to have to pay for them. So where's the freedom
Mhm.
in that? And you and I discussed on that show when that happened about the fact that that now changes the freedom for for you to have your children get COVID vaccinations in large part because they've restricted that. And that was over the objection of the FDA scientists who said that it should be authorized for children, all children 6 months and over. And then another one of these appointments, Dr. Vinay Prasad, who in your tee up to the show, it was mentioned he just resigned, praise God, or was kicked out, one or the other. I don't care. I'm just glad he's gone. But he's the one that overturned that decision. So they are not doing things that promote medical freedom, in my judgment. And uh, frankly, the decisions they're making are not making us healthier. And we will see this show up in the data over the ensuing number of years as we see that, in
Mhm.
fact, chronic diseases get worse and we have more childhood morbidity and mortality.
Okay, so speaking of things like chronic diseases, there is word that RFK Jr. may potentially be looking at dismantling the U.S. Preventative Services Task Force. So, Dr. Pay, tell us what this task force is.
This is a very important independent. So these are not people who work for the government. These are people who do primary care, have expertise in providing primary care services. And what we're talking about is a committee that reviews the evidence. So things like, at what age should a woman begin having screening mammograms? At what
Mm.
age should people begin having colon cancer screenings? Those kinds of criteria. They review the massive amount of data that's out there and studies, and they synthesize that and discuss among themselves and make a recommendation that, okay, it should be at age 40 or it should be at age 50. And then they answer the question, well, and then how often after that? Things like that. Now, why this group is important is, first of all, that's a lot of work and it makes it a lot easier on primary care physicians to have that recommendation that's based on science and evidence. And then what's important about it is that um, their recommendations, if accepted, under the Affordable Care Act, so since 2010, it means that if they give it their high recommendations, then
Mhm.
insurance companies have to cover that. as preventative care if they are ACA compliant plans, which most of them are. So that is a huge benefit to people. That means more people get screened. What I and others who follow this are very fearful of, that this is exactly part of the playbook, and that that he is in fact going to summarily dismiss all of those experts, put on people that have the crazy notions that he has, and they're going to revoke many of these standing recommendations. And now we've already talked about that we're seeing colon cancer in
Mm-hmm.
young adults more than we've seen.
Mm-hmm.
If they reverse that recommendation, people aren't going to. A lot of people aren't going to be able to afford to get these screening studies. It's going to be bad. It's part of the a series of steps to dismantle our health infrastructure.
Mm. I appreciate that, telling us what this task force is and what that could mean if it is dismantled. At this point, of course, Health and Human Services isn't commenting much, but we will, of course, keep an eye on that. Dr. Pate, some potentially groundbreaking news in regards to a vaccine for cancer. Can you talk to us about these findings? This was from a recent study that some scientists at the University of Florida just released.
Yes, this is really, really good news. It's not proof yet, but it is certainly very encouraging that this strategy could work. And it's not the first time this came has come up. I think it was probably about 15, 20 years ago. We saw some evidence that people with glioblastoma, which is a terrible, terrible cancer in the brain, that if you gave them a diphtheria tetanus vaccine or the tetanus toxoid, that actually that helped regress the tumor. And what the apparent mechanism is that as the body responds to the vaccine by ramping up its immune response, it also ramps up the immune response against the cancer. What's important about this recent study is that, like we've talked about how viruses can develop resistance, they are evolving and changing. Cancers oftentimes are learning the tricks of how they can evade the immune system. And
Mm,
so they have a number of tricks how to do this. And what this study did was kind of a two-pronged strategy. The first thing is they give a drug called immune checkpoint inhibitors. These are newer drugs that we've been using, and basically, a checkpoint is something that happens with healthy cells to make sure that our immune cells don't attack it. And then what cancer cells have done, have they kind of co-opted the same strategy, and so it can kind of send the message to our immune system, oh, leave me alone, I'm normal, nothing to see here.
mm,
What the immune checkpoint inhibitors do is prevent the cancer cells from producing the protein that is sending that message, so that the immune system doesn't get fooled and will attack it. And then the second part of the punch is they give a mRNA vaccine, which has the actual protein that the immune cell is known to attack on the cancer cell, and just goes ahead and revs that up. So it's a 1-2 punch. It was very encouraging. We got to do more studies. We got to try other cancers. We got to do it in humans. But there is lots of reasons to have encouragement. The problem is that we have people like in the Idaho legislature who think mRNA is bad. They
mm-hmm.
don't understand the science, or they're doing it in spite of understanding the science, and they're trying to outlaw the use of those vaccines, when these vaccines may be the key to treating cancer in the future.
Well, they'll probably change their tune if it's for cancer. I would think some folks might be seeing it a bit differently. I could be wrong, Dr. Pate, but
Well,
I
I love sweet, naive Gemma. I just love it. So I hope you're right. I pray you're right.
Oh, well, I appreciate that. All right. We actually have some listener questions. Philip wrote in, Dr. Pate. He's got quite a few. So I want to start with this. He asks, since healthcare outcomes are important to everyone in Idaho, then why doesn't Idaho participate in the major healthcare outcome and quality measures, such as programs like the National Inpatient Sample by the Agency for Healthcare Research and Quality? Many of these measures are optional. Interestingly, Idaho is only one of 4 states in the United States rather, which does not participate. So he wants to know, why is that?
The short answer is I don't know. That decision was made like 2 decades before I came to Idaho. So I really wasn't following, shockingly, what was going on in Idaho at the time. I was in Texas, and Texas did decide to participate. However, the reason we did is we did it through our hospital association, and it allowed hospitals to get access to some of the data. I can well imagine why Idaho may have made the decision not to do this. First of all, this is only hospital inpatient data, or at least let me say, my experience with this all dates to my time in Texas. So I haven't had experience with it for 16 years. So things could certainly
Mm,
have changed. But it was just hospital inpatient data. And the problem with that is that for example, if you want to follow complications of surgery, not everybody has their complication while they're in the hospital. As you know, we are sending people home earlier and earlier after surgery because we've got new technology and stuff. And so if somebody goes home, then gets an infection, gets readmitted, it's not going to capture that. It also isn't going to capture it because the patient information is de-identified, so you have no way of connecting those two. The other problem, while this is very good for researchers that want to look at the entire country and decide, what are the trends going on with utilization, costs, those kind of things. The problem is because the data de-identifies hospitals and patients, really to somebody like me running a hospital or a set of hospitals, it's not going to be very helpful to me. One, because especially back in those days when Idaho would have made that decision, there was a significant length of time gap before we got the data, so it almost
mm,
wasn't helpful in that regard. And second of all, you couldn't tell. Well, wait, was this a problem in the rural hospitals? Was it a problem in the major hospitals? Is it a problem in one part of the state, all the state? It just had limited utility. Plus, you have to pay to get the data after you submit for that. So the reason it worked in Texas is that we submitted that data, but the hospital association would also give us our hospital specific data, but it was also very, very expensive. So I
mm.
can't tell you for sure why not, but those are some of my guesses.
So we got another email from a listener, Dr. Pate, wanting to know, why is there a physician shortage in Idaho, and what are healthcare employers doing about the problem?
Well, there is a shortage in Idaho for many reasons. First of all, there is a national physician shortage. Second of all, for a lot of doctors that are looking to practice, they're not necessarily looking for rural areas to
Mm,
practice in. They want more security, they want the opportunities of larger urban centers. A third issue in Idaho is that we don't have a large number of residency programs. We have been building on that and we are increasing them, and I'm wholly supportive, and I think that's great. But where a doctor ends up practicing is much more higher correlated to where they do their residency training after medical school than it is where they do their medical school. Now, we've added a medical school here to Idaho that will no doubt help, but it's not likely going to be enough. The other thing is that, frankly, in the last 5 years, we have seen the legislature make a lot of moves that really don't make this as friendly an environment for new physicians to want to come here. We've especially talked about why OB/GYN doctors are actually leaving the state, not coming in. And it is hard. Now, as far as what our Idaho healthcare employers doing about it, they're recruiting these physicians. They're trying to attract them, and they're trying to
Mhm.
retain them because most physicians don't want to go into private practice these days. But now you look at, we're going to have the Medicaid cuts that we talked about before. That is going to put rural hospitals in danger. And the problem is, if you have a new physician you're trying to recruit here, are they going to go buy a home, move their family in a rural area when they don't know if that hospital is going to be there in 3 to 5 years? And so it's a very complicated, lengthy whole set of factors that are contributing to this. But frankly, our state could do a lot more if we could get the legislature to be more supportive of healthcare and healthcare providers.
The listener also goes on to ask about the differences in nurse practitioners and physician assistants, and they want to know, should nurse practitioners or physician assistants be allowed to act as healthcare providers in hospitals or doctors' offices? I have to tell you on a personal note, Dr. Pate, I see a nurse practitioner instead of an OBGYN anymore because frankly, I'm not having babies anymore and we have a shortage of OBGYNs and I could more easily see a nurse practitioner than an OBGYN.
Absolutely. And so this really ties in well with the point we just discussed. When we have a physician shortage, uh, it's really imperative that we utilize physician assistants, nurse practitioners, and so forth. But second of all, it really is a benefit. Like you, for some things, I've had a nurse practitioner managing my care. And she would frequently ask me, "Hey, do you want to see the doctor on the next visit?" And I'm like, "No, I'm fine with you. You're doing a great job." And the other thing is that a lot of times, especially if you want to get in sooner for a problem, you're
Hmm.
going to have a better chance getting into a PA or a nurse practitioner, as you mentioned, than the physician in many cases. Really, the most effective way to do this is when all of us are working as a team. At St. Luke's, we utilize many PAs and nurse practitioners, and I think it makes for better healthcare. You get more different perspectives, more backgrounds, more experiences working, and we can work together. And you can actually allow the physician to see more patients by having that team based approach.
Well, as always, Dr. Pate, so appreciate you. And remember, folks, if you have public health questions for Dr. Pate, make sure you send them to us, Idaho Matters at boisestate.edu. And we always send them along to Dr. Pate so he can answer them for you. You've been listening to Idaho Matters from Boise State Public Radio. I'm Gemma Gaudette.